Thank you, everyone. I'd like to call this meeting to order and to confirm that we have a quorum. We have a full agenda, so I think we should get right to it once we've approved it. Could I have a motion to approve this agenda? Thank you, Jim, and seconded. Thank you, Kevin. All in favor? Opposed? Motion carried. Minutes of January 27th and May 22nd have been distributed. Judith, where's Judith? There she is. Did you get any comments from anyone? No? Are there any last-minute comments on the minutes? No? Great. So could I have a motion to approve? I'll ask the same two, perhaps. Oh, thank you, Marianne, and thank you, Jim. Motion is presented. All in favor? I see hands raising. Opposed? Thank you. Motion carried. So we have as item 4, as usual, our consent items and resolutions. These are items that have been vetted by each of the appropriate committees, human resource, finance and audit, real estate, and resolutions of professional services directorate, council of CPTP, and ethics committee. I would like to know whether I have a motion to approve, and I would remove the last one because we did not cover it in the board meeting, in the in-camera board meeting. So 4.5.2 we will deal with at the end of this meeting as it's on the agenda, item 6. So save that item. Do I have a motion to approve the consent items? Thank you, Samira, and I can't see thank you, Jim. Sorry, I don't see everyone on the screen at the same time, so I appreciate your indulgence. Any questions or comments on the consent items? I hear none. So I will call for the motion. All in favor? Okay. All against? I declare the motion carried. Thank you. Item 5, Dr. Feller, is the report of the President.
Alors, le 22 juin dernier, on a eu des changements très importants à la direction du ministère de la Santé et des Services sociaux. Il y a eu un changement de la ministre et du sous-ministre la même journée, ce qui n'arrive pas très, très souvent dans l'histoire, qui n'est pas souvent arrivé dans l'histoire au Québec. Le nouveau ministre, c'est M. Christian Dubé. M. Christian Dubé était ministre responsable du Conseil du Trésor, donc président du Conseil du Trésor auparavant. M. Dubé, c'est sa deuxième élection avec la CAQ. Il avait été élu lors de l'élection précédente, mais avait quitté en cours de mandat pour retourner à la Caisse de dépôt et de placement, où il avait un poste de direction supérieure. C'est un monsieur qui est comptable professionnel agréé et qui a fait sa carrière dans le domaine des affaires, de la finance et de la comptabilité. La nouvelle sous-ministre, c'est Mme Dominique Savoie. Elle avait été ajoutée au personnel du ministère de la Santé alors que M. Gendron est encore en place déjà durant le mois de mai. Donc, elle est maintenant officiellement la sous-ministre en titre depuis le 22 juin 2020. Il y a également eu d'autres changements au ministère avec le départ de Pierre Lafleur, qui était le sous-ministre associé, sous-ministre adjoint, pardon. Et Pierre Lafleur, c'était vraiment comme le gérant général du réseau. Pierre Lafleur a été nommé comme vice-président de la Régie de l'assurance maladie du Québec. Par ailleurs, le mandat du Dr Horacio Arruda a été renouvelé par le Conseil des ministres la semaine dernière. Qui va remplacer Pierre Lafleur comme sous-ministre adjoint, il y a eu la nomination de Vincent Lehoulier comme sous-ministre adjoint la semaine passée. Mais pour l'instant, ses responsabilités demeurent dans le domaine de la direction des ressources humaines, des communications et des affaires juridiques. Donc, de nouveaux acteurs importants. So we've had contacts already with these people. I had the chance to speak with Monsieur Dubé twice. The first time being on a phone conference with all the CEOs. The second time in a small group meeting, only 5 CEOs, Monsieur Dubé and Madame Savoie, where he wanted to ask questions about what happened during the first wave of COVID. So there were 3 CEOs from the Montreal area. I was representing the university hospitals, and 2 from the suburbs of Montreal. And it was a very good discussion. It was supposed to last about an hour. It lasted an hour and a half. And so we've made first contacts with the new team in Quebec City. I have to say that I think the contacts have been very positive. They recognized the role that we played during the first wave of the COVID, the very good results we got both at the MUHC and also at Lachine, of course, with Camille Lefebvre, that was brought forward in a press article dans la presse about 3 weeks ago. So we're being recognized for our expertise in IPC, and already our expertise is being used somewhere else where they have needs in this field. A new coordinating structure has been created in Montreal in provision for the second wave. That will be coming, we don't know when, probably in the fall. Hopefully we won't have a second wave, but it's very unlikely. Most pandemics always have a second wave. We were somewhat worried last week when the percentage of positive tests in screening the population increased to over 3% for a little while. It has come down since then. It was probably the effect of the things that have happened on the South Shore and also downtown Montreal over the last few weeks with the deconfinement. So the next steps, of course, with the new leadership in Quebec City will be to meet them, to discuss and to put forward some projects. Of course, it's a big ministry. These people are new to this ministry. They're obviously informed citizens, but they don't know all the ins and outs of the ministry. So we're going to try to get a meeting to tell them about our different projects, renovating the Montreal General, the Neuro, Lachine project, which is going forward quite well at the present moment, and also proton therapy. The other project that we had put on the agenda for this year and will be covering in the fall, we'll have an update on the objective that we had given ourselves for the year 1920. We'll cover that at the fall meeting of the board. But the other thing was OPAL. This afternoon we have a meeting with Minister Carman about the OPAL app and its implementation in the entire network. So as far as COVID is concerned, the number of cases is still diminishing at the present moment. We are making strides in our state of preparedness for the eventual potential second wave. It might be different, but we'll be more ready, we'll be more experienced, we'll have tested our expertise already during the first wave. PPEs should be more widely available, even though we always had the PPEs that we needed for the different clinical situations during the first wave. It was sometimes tight, but we had the PPEs all the time. Of course, we've also developed an expertise in reusing PPEs with different protocols. So we had time to do that. So what role will we be called upon to play during the second wave? At the present moment, we're still expected to have to take care of a large number of COVID patients during a second wave. But this is still under discussion, and there was always on the part of the ministry a wish to be able to adapt to the situation. There is some literature coming out from European countries about the advantages of keeping some tertiary and quaternary hospitals cold in order to maintain access for cardiac patients, cancer patients, trauma patients, all these patients who are not COVID plus but do require specialized care. So discussions are ongoing. The management of the hospital has moved back or basically moved back to normal with comité de direction, comité de régie qui recommence à se rencontrer. Nous aurons un comité de régie la semaine prochaine et un comité de direction d'ici quelques semaines. Le CCMU qui se réunissait au pic de la pandémie 2 fois par jour, 7 jours par semaine, se réunit maintenant environ 2 fois par semaine et on ajuste selon le besoin. Donc, nous sommes prêts pour une éventuelle deuxième vague et nos équipes sont mobilisées pour s'occuper des patients qui nous seront référés ou qui se présenteront chez nous. Les résultats financiers de l'année 19-20 sont présentés aujourd'hui par Mme Singerman. Les résultats sont très bons. Ce sont les meilleurs résultats que nous avons eus en 5 ans, avec un léger déficit de quelques millions de dollars. Je vous rappelle que le budget de l'organisation est de 1,4 milliard de dollars par année. Donc, on est bien en dessous du 1% où on est en zone de difficulté avec le ministère. Par contre, ces résultats-là, excellents cette année, ne sont pas structuraux. C'est-à-dire qu'ils dépendent, entre autres, d'un surplus accumulé au fonds d'immobilisation en lien avec le garage du Glen. Et donc, ce surplus-là sera non récurrent. Il ne sera pas là l'an prochain, cette année, en 2021 ou en 21-22. This year, as I was saying earlier during the in-camera session, is a really, as far as finances are concerned, it's really a transition period, because the budget which is submitted to the ministry doesn't take into account everything we're doing for COVID. So it's a somewhat theoretical budget, and but at the same time, we have to get ready for the year 2021-22, when we will probably have the vaccine and COVID will be behind us, hopefully. So we'll get back to a more normal mode of functioning. And we still have a lot of work to do in optimization and taking a look at our activities in order to get back to balanced results in 2021-22. This will be unlikely in 2021 because of the COVID situation, and also because our people have been mostly busy with the COVID over the last few months since April the 1st, and might be very busy with COVID in the fall or in the winter as well. On a certaines difficultés de personnel à la Chine, surtout du côté du nursing spécialisé, les soins intensifs, l'urgence. Le contexte de recrutement et de rétention est difficile à la Chine. Il est différent de celui du restant du CUSUM. Donc, c'est quelque chose sur lequel on travaille beaucoup. Je veux remercier les personnes qui sont portées volontaires. We've had, Chantal, was it about 20 nurses who were volunteers? 9? Okay, so it's 9. We have 9 nurses who have volunteered to work at La Chine. I thought it was 20. I gave this information during the in-camera session. I'm sorry. So I'll be visiting La Chine this week. Je vais aller faire un tour là-bas pour constater la situation avec l'équipe des cadres supérieurs de médicaux et nursing. On va aller faire un tour à La Chine cette semaine. Aussi pour entendre les médecins, parce que la Chine, à l'heure actuelle, ne fonctionne pas de façon optimale, entre autres au bloc opératoire, à cause du manque de personnel. On a pris du personnel pour les affecter à la COVID, donc dans les tentes extérieures, et pour s'occuper des patients COVID, parce que la Chine doit demeurer un hôpital froid, donc les patients doivent être transférés dès que le diagnostic est fait. Donc, il y a eu un retard important dans les volumes de chirurgie qu'on réalise généralement à la Chine. Le docteur Siderovitz, notre directrice médicale aujourd'hui, va nous dépeindre un tableau de la situation des listes d'attente avant la COVID et après COVID. Alors, aujourd'hui, il y aura une présentation par Mme Souligny sur la nouvelle politique des visites. There will be a discussion on equity, diversity, and inclusion. And as I said earlier, Dr. Siderovitz will be telling us about the ramping up and the state of our waiting lists. Voilà, Monsieur le Président, c'est mon rapport du PDG.
Bonjour tout le monde. Good morning, everyone. Mon nom est Dawn Singerman. Je suis la directrice des ressources financières au CUSUM. Comme Dr. Feller l'a mentionné, on a eu des très belles résultats cette année. If we look at the results of the CUSUM from a net deficit level for the last few years, as you can see, the curve is coming up nicely. We had a really good year this year. We ended at $2.8 million deficit. I want to just bring everyone's attention to the fact that that's net of any of the costs that were incurred for COVID. We incurred about $5 million of costs, but the ministry is financing those. So these results, they're an in and an out in these results. The big help for this year, which you'll see on the next slide, is that the financing arrangement for the Glen parking has been rectified with the ministry, and we've redone the financing for that piece. That resulted in a surplus in the Fonds Mo, which you can see is the green bar in the last column, of $15.6 million for this year, which offsets effectively the deficits that were recognized in prior years. From an operating perspective, the deficit this year was $18.4 million, which is a little bit worse than the last couple of years, but much better than the years that we had before that. The main difficulties that we're having are really common issues, sont partout dans le réseau. For us, the expensive drugs are mainly oncology and Spinraza, which is for a neurological disorder. They were not financed entirely by the ministry, so we had a deficit of $4 million. On a, comme tous les autres établissements dans le réseau, des problèmes de main-d'œuvre. So, pour nous, ça nous cause des problèmes en termes d'assurance salaire, de l'overtime et beaucoup de coûts de formation. Nous avions la pression dans les salles d'urgence, les salles d'op, une manque de lits, que les discussions avec le ministère cette année, on a eu certains financements été accordés pour ouvrir des nouveaux lits. On était capable de faire certaines choses, mais ça demeure encore un problématique et un enjeu pour nous et d'autres établissements. And we also had last year, the Ministère de la Santé set some very significant optimization targets or budget cuts for the volet de santé physique, which is the main part of our budget. We do have some in santé mentale and some in some other buckets. But these were steep optimization targets that we're still working on finding the ways to get through them and implement the changes we need to implement. That's about all I have to say. I don't know if anybody has any questions in particular. Merci tout le monde.
Monsieur le Président, je réalise que j'ai manqué quelques diapos qui avaient été préparés. Et c'est pour ça que tout le monde était surpris. Puis Dawn a demandé si c'était son tour. Toutes mes excuses.
On va vous laisser
je vais terminer.
Continuer après cette apparition de Dawn.
There might be questions for Dawn from the board.
I will ask the board if there... Do you see any hands, Tina? No? Okay. We can have those questions as well at the after Dr. Feller has completed the second half of his presentation.
Yeah.
He's trying to confuse the chair, and he's very successful.
I'm confused myself, actually. Alors, I forgot to mention that on June 17th, we did inaugurate the new MGH dialysis unit on B7 at the Montreal General. We're really happy because it's really a beautiful environment for our patients. At the present moment, we have only 9 stations there, but we're really thinking of bringing the entire hemodialysis unit to this location. So great work by the team in hemodialysis, and also great work, of course, by our technical services team. New parking rates have been effective on June 20th, as everywhere else in Quebec. That's a government policy. So, and we will be compensated for the delta in parking revenues by the ministry. Air conditioning, we did discuss that during the in-camera session. The Montreal General Hospital now, all the rooms have been they have been renovated, so they all have AC. And we started last year and we finished this year. Everything was done before La Saint-Jean-Baptiste. So it's a big plus for our patients. Camille Lefebvre, of course, we're using dehumidifiers, and upon request, AC units are available. A lot of work has been done at the General, at the Glen site, at Lachine to prepare for the COVID. At the same time, there was a presentation with all the details for the board during the in-camera session. So the Chief Scientific Officer, the search for a new Chief Scientific Officer has started again. And a search committee was created from all the groups of stakeholders in the organization. We have a very strong committee, which is chaired by Mme. Martine Alfonso, our PDGA, and Dr. Leslie Fellows, who's the Vice Dean, Academic Affairs, McGill Faculty of Medicine. The committee is already at work. Call for applications is underway until July the 31st. And, of course, we are not involved in this process. We're awaiting recommendation from the committee. So, but we know that the work is already underway. In the meantime, since Dr. Bruce Mazer stopped serving in the capacity of interim CSO, which he had done since the fall of 2016, but he had also graciously agreed to extend his term until June the 15th, 2020. So starting on June the 15th, 2020, Dr. Miguel Bernier, who's an ophthalmologist and a scientist working at the RI, of the highest stature, I must say, did accept the appointment of interim director and chief scientific officer of the RI, beginning on June the 15th, and he's already at work. We're already having meeting with Dr. Bernier, and a motion was voted by the Board of Governors of the MUHC earlier today to express our sincere gratitude to Dr. Mazer for the work he has done over the last 4 years. We do have awards. Dr. Alan Evans, he's a recipient of one of the 5 prestigious Killam Prizes, namely the one for health sciences that was done on May 27 by le Conseil canadien pour les arts. These prizes are awarded yearly to Canadian scholars who have made a significant impact in their respective fields. Dr. Evans received his award for his work furthering the understanding of the human brain. Le docteur Emmett Franqueur reçoit le prix Le Tondal 2020, qui est accordé par l'Association québécoise des pédiatres pour une contribution de carrière importante à la médecine pédiatrique. Alors, l'Association des pédiatres reconnaît ainsi le travail de développement, le travail sur le développement de l'enfant qui a été fait par le docteur Franqueur durant sa carrière exceptionnelle de 45 ans au Montreal Children. Il a été mon résident senior il y a de cela beaucoup d'années. Alors, je l'ai connu il y a très longtemps déjà. Ça m'a fait plaisir de le revoir à mon arrivée ici au CUSUM. Finalement, c'est avec une grande tristesse que nous devons vous annoncer le décès de M. Hichem Motanem, notre directeur des ressources informationnelles au CUSUM. Alors, ça a été une perte immense pour sa famille et aussi une perte immense pour notre organisation. Dr. Carman n'était pas au courant que M. Motemem était décédé. Puis la semaine passée, je lui ai dit, vous savez, avec le départ d'Hichem, ça a changé beaucoup de choses. Il m'a dit, il est parti où? Je lui ai dit, il est décédé, il n'était pas au courant. Alors pour lui, il dit, écoute, on a perdu un des meilleurs directeurs de technologie de l'information dans le réseau. Dr. Carman ne se gênait pas pour l'appeler quand il avait des questions à poser, pour comprendre des choses. Donc c'est vraiment une grande perte pour le réseau, pour sa famille aussi. On a eu la chance d'échanger avec sa famille et avec son équipe lors d'une conférence Zoom récemment. Et j'ai eu la chance de discuter avec son épouse peu après son décès. Donc, c'est une grande perte. Pour l'instant, le poste est occupé par M. Keith Woolridge sur une base intérimaire. M. Keith Woolridge est aussi notre directeur de l'évaluation performance-qualité. Voilà, là, je pense que j'ai terminé ma présentation, Monsieur le Président. Toutes mes excuses.
Vous avez terminé, à moins que vous souhaitez présenter une proposition de résolution pour reconnaître le travail énorme de Hichem.
Oui, on pourrait, ça me ferait plaisir de présenter cette résolution-là. J'ai déjà envoyé une lettre à Madame, mais je pense qu'on pourrait reconnaître, le conseil d'administration pourrait reconnaître le travail exceptionnel qui a été fait par Hichem, aussi son apport humain à l'organisation, pas seulement technique. C'était un homme d'une grande culture, d'un grand savoir, et aussi beaucoup de savoir-être avec ses collègues. C'était quelqu'un de très, très agréable, qui était apprécié de tout le monde. Donc, autant pour ses qualités professionnelles que personnelles, je pense que ça mériterait d'être souligné. On pourrait prévoir là, la rédaction d'un texte, d'une proposition qu'on pourrait vous présenter dans un deuxième temps, qu'on pourrait acheminer à sa famille, à sa femme et à ses enfants.
Ce serait excellent. J'ai eu le plaisir de le reconnaître aussi et je me joins à vos commentaires. Alors, j'appuie la motion et est-ce que on peut demander une vote? Est-ce que tout le monde est d'accord avec cette résolution? Je vois les mains levées et je ne demande même pas s'il y en a contre. Je m'en fous. Merci, docteur.
Merci.
Excellent. Don, merci encore pour la présentation. Je pense que c'est le tour à Eva. Dr. Sidorovitz.
C'est ça. On a demandé au Dr. Sidorovitz de nous présenter un peu le portrait actuel des activités, du niveau d'activité clinique qui n'est pas COVID. Puis en même temps, il y avait une question spécifique des membres du conseil d'administration qui voulaient avoir une idée de comment étaient nos listes d'attente, surtout en chirurgie, en février versus aujourd'hui, quel est le delta. Alors, donc, Dr. Sidorovitz va essayer de nous éclairer là-dessus. Voilà, madame.
Alors, bon après-midi. Happy afternoon, I guess, to everybody. And to thank you very much for that motion for Hichem. I think it's very much appreciated. Je voudrais vous faire une petite mise à jour sur la reprise des activités. J'avais fait une présentation, je pense, lors de la dernière rencontre, mais évidemment, les choses avancent et progressent. Donc, je vais faire ma présentation en deux temps. Je vais vous parler des sites adultes pour commencer et ensuite de l'hôpital pour enfants. Donc, la première partie, c'est vraiment pour les inpatient units, les unités d'hospitalisation, et vous constaterez que les choses ont évolué massivement depuis le 22 mai. Et en fait, si vous voyez qu'au mois d'avril, nous avions jusqu'à 108 lits réguliers pour les patients COVID. Maintenant, au mois de juillet, nous n'avons conservé qu'un seul pod au Glen qui est à moitié vide présentement. Donc, ce matin, on avait 5 patients positifs sur les unités régulières au Glen et un patient aux soins intensifs. Et depuis la semaine dernière, l'hôpital général est redevenu a cold site. So the general, since last week, is a cold site. Just to remind you that the neuro and Lachine have been cold since the beginning, so no COVID patients. But now the general has joined that, so we're quite happy about that. It makes a huge difference in terms of our ability to resume activities. Obviously, the emergency room at the general is still has a setup in the emergency room for rule out COVID, so there's a safe place for them to go. But should there be a positive patient, that patient will be transferred to the Glen. Again, just to remind you that the ramp up plan also integrates into it a ramp down plan so that if we need to flip the switch in the next few weeks as deconfinement progresses, well, that is kind of built into the plan. But for the moment, we're still moving forward, and last week was a good week for the general. So a bit of a snapshot here of where we're at with the adult surgical and interventional platform activities. So in terms of the ORs, I think the last time we spoke, I told you we were at about 40%. Well, now we're up to 70% of regular OR activities. So that is good progress, though probably for the rest of the summer, we won't be able to go much beyond that. In angioradiology, so interventional radiology, we are at about 80%, and that will probably remain as such. In the cath lab and cardiology at about 65%. In the electrophysiology lab, we're sitting between 50 and 71%, depending on the type of procedure. Some procedures are at 50%, others have been able to ramp up a little bit more. The area that remains of concern is endoscopy. When I last spoke to you, we were at about 10-15%. We've been able to go up to 30%. Though this week, with the release of further staff, again, I reminded you that this whole exercise is contingent on releasing staff from the critical areas back to where they normally work.
Alors, en endoscopie, justement, cette semaine, je pense qu'on va voir une augmentation des activités étant donné que le personnel a été replacé. Donc, on a bien hâte de voir ça. Je vous rappelle que pour aller plus loin, il y a toute la question des ressources humaines que je viens de mentionner, donc des gens qui ont été déplacés, mais aussi maintenant, les gens prennent des vacances bien méritées. Tout le monde est très fatigué, donc je pense que ça aussi, ça vient jouer dans l'équation de la reprise. Évidemment, la planète a changé, donc tout ce qui a trait à l'organisation des soins, pré- et post-intervention a changé, donc il y a des mesures supplémentaires en place et certaines de ces mesures-là, évidemment, ralentissent un petit peu le tempo au niveau de ce qu'on peut faire. So now some numbers, and so I think this is an important slide here, and I've got in one slide, so there's a lot of information. We have the general, the Vic, Lachine, and the neuro as of last July 9th was last Thursday, I believe, so in terms of the data. I didn't put here the overall wait list, which is much bigger than this. So if you put in there the patients who are waiting for more benign conditions, we're looking at a wait list which is probably closer to 2,500 patients. So there are a lot of folks there. But I did think it might be of interest to focus on the oncology patients. And for those patients, as you can see, we have a total of 289 over our 4 sites. And in fact, at Lachine, it's one less than that. It's 4 patients, and there's only one that is over 56 days. But you can see here the number of patients who have been waiting for more than 56 days. What I want to also mention here, these are the kinds of numbers that we report to the ministry, but actually at the VIC, out of the 33 patients who are over 56 days, at least half of them have either already been booked, so they do have a date for their surgery. It's just that it's coming up imminently, so they still got caught in that count of 56 days, or they're not available either for personal reasons or because they're undergoing some other investigation for another medical condition, or getting chemotherapy, or getting radiotherapy. So it's not the full 33 that are still actually waiting. At the general, it's about half the patients, so half the patients have already been booked or are not available for any number of reasons. As you can see at the neuro, that number is 0. And the neuro actually has been running their ORs almost at normal capacity for many weeks now. So things are actually quite fluid at the neuro, which is quite excellent. At Lachine, as Pierre was mentioning a little bit earlier, on a un problème de personnel et la reprise des activités est beaucoup plus compliquée au niveau du bloc opératoire. Je vous ai mis un tableau avec les patients en attente de 1 an et plus. Vous vous rappelez qu'il n'y a pas tellement longtemps, on était très fiers de vous dire qu'on n'en avait plus ou très peu. Et ceux qui étaient là, c'était des patients qui avaient des conditions très spécifiques. But unfortunately, as you can see, on July 9th, these numbers have gone, are significant again. We have overall, on the adult side, over 200 patients. You can see there are quite a few at Lachine, considering the size of the site there, and a lot of those patients are ophthalmology patients waiting for cataract surgery. We have not been able to do any cataract surgery since March at Lachine, so the patients are really piling up there. So that's a very big concern, and you can see there are patients across the other sites also, but in smaller numbers. So we're starting to tackle those again and trying to make sure that they get booked. One of the challenges that we're having, and sorry, before I get there, you can see in cardiac surgery also there are some challenges there. We have 74 patients on the wait list right now, and almost half of them are hors délai. And that is an issue of the match between the need for surgery and the fact that our OR platform isn't able to offer more time. So that's a concern. And again, this is something that I have my eye on every single week, and we try to make sure that the patients who are the most hors délai are booked as a priority. There's some numbers here for orthopedics also, but it's really just a snapshot of a specialty. The challenge here is that for the patients who have non-malignant conditions, and non-malignant does not mean that the patient's not suffering or that they're not having significant morbidity right now. And I had an exchange this morning with our head of gynecology. And this is something that has come to attention of the waitlist committee, and we're trying trying to make sure that some of these patients are also scheduled as quickly as possible. But the overwhelming le constat here is that it's going to be very, very difficult to get rid of the backlog of patients right now, and it's a very large challenge. Now, as you probably heard, the ministry has organized some platforms outside of the hospitals to take care of some of this backlog, and we are in the process of negotiating two ententes right now, one with Rockland and one with the Eye Institute. So unfortunately, those ententes are not quite finalized. We're hoping, I'm looking at Dawn right now, there's some significant financial issues with these ententes, and we're having a meeting with the ministry this week to nail those down and to be able to go forward. But even with the help of these two private clinics, it will not help us 100% to get rid of the backlog. So this is a weekly, almost daily concern for all of us. Here's a snapshot at medical imaging, and so just to walk you through this very quickly, it's actually kind of interesting. We have all three modalities here for CT, MR, and PET. And you can kind of see that the periods here are the periods of the pandemic. So we have P13, 1, 2, and 3. And what is actually quite striking to me is that the number of waiting patients hasn't gone up significantly. In fact, in some cases, it's the numbers have gone down if you look at the CT numbers and the MR numbers in a fairly significant way. But what has been impaired, and that's the number in brackets, is our ability to respond to these patients in a timely fashion. We were actually doing quite well in P13 with patients accessing, and again, these are not inpatients or ER patients, because obviously those patients access in a very timely fashion, but these are the scheduled, the elective patients. And so because of all of the reorganizations that have occurred with COVID, also the fact that the activities were way down, we're having a bit of a hard time responding to these patients in a timely fashion, and I'm obviously working on that with Michel Picard and Diego, but actually I think this slide illustrates that point quite elegantly. The ambulatory, again, I'm speaking about the adults here, we're actually up to a good 75% of our previous volumes. In some cases, the clinics are approaching 80 or 90%, so we're doing very well in ambulatory. This, though, does include telehealth modalities. Not all patients are coming in person to the clinics, but they are being taken care of, and I think that's the important part. I just put a little note here that in oncology, in fact, they're having a bit of the opposite problem. Patients have been coming throughout the pandemic, and they're actually trying, and their volumes are well above 80% of normal, and they are actually putting in measures to make sure that patients are socially distancing and that measures are put in place with respect to scheduling so that they are handled in a safe way. So, but the volumes really in ambulatory have bounced back quite significantly with all of the measures that have been put in place. Just a little reminder of these bubbles that I presented at the last time, so sort of our overall orientations in terms of ambulatory. So all of this is being worked on right now. We're reviewing the pertinence of the visits, so the equilibrium for each service between in-person and virtual visits. Obviously, there's a lot of work being done with Chantal's group with respect to the layout of the waiting rooms, the scheduling, the timing of the visits, all that sort of stuff. We're looking at the resources that are required to support this new way of functioning. In fact, it's a fascinating laboratory that is happening right now in our clinics. What's very important also is that there's been a review of governance, so there's a much tighter coupling between the physician leads and the nursing lead in each clinic for decision-making, for organization of the clinics, and I'm very, very happy about that, and it's really happened throughout the MUHC, so I think this is a good, not just for COVID, but I think going forward, I think it's really a guarantee of success. And obviously, the whole educational aspect of ambulatory visits is being revisited. We have obviously Dr. Khalil, who's our Director of Education, is very much involved with the medical faculties, but also the other schools to make sure that the reintroduction of learners is done in a safe way and that they also develop new skills with respect to teaching. So that's for the adult sites. For the children's, as you may recall, the children's had 3 separate streams, again, logically organized. And I must thank Tanya DeGenova for these slides. She's obviously the motor and energy with the rest of the team at the children's, besides the sort of organizing the framework for the ramp up. And you can see some numbers here for the outpatient stream. Again, the children's, same kind of logic. Some patients are coming in, some patients are being seen through telehealth. You'll notice on the medical clinics that there are about 42% of patients coming in and 84% of patients being seen by telehealth. And I was discussing with her on the weekend, how is that possible? That's more than 120% if you add them all up. And they're actually looking at this phenomenon, but it's quite possible that they're seeing more patients than before and basically chipping away at the wait list by offering patients an alternate way to access the doctors. So she's going to tell me a little bit more about that in the next month, because they have some students actually from management looking at this phenomenon, and it'll be interesting to see how that is explained. But if it is an increased access, then that is bravo, that's wonderful. In terms of the inpatient stream, other than the pod that was being kept for possible COVID patients, which is now being remodulated, the inpatient units are really quite full. I was looking at the numbers this morning. The children's is running full steam. And the same thing for the ICU. There is occupancy there responding to post-OR and other critically ill patients. The peri-op stream has also picked up nicely. They're up to about 75-80% of their pre-COVID activities. And again, this comment that in order to do that amount of work, you're using up about 96% of the resources, again, because of the need for protection, a little bit more time for the turnaround between patients, et cetera, et cetera. And for the children's, the hors bloc ramp up is at about 60% right now. Some numbers. This is specifically for the surgical wait list. So here, Tanya has supplied June 2019 and June 2020, so that you can see they're actually one patient difference from one year to the next. So the wait lists have not ballooned. Again, one could say, well, the patients perhaps have not been seen, so they don't know yet that they need to be on the OR list. So we'll see what happens to that over the next little bit. And as you can see here, what's interesting is that we again have more patients waiting for 9 months or more, and there probably are some 1 year plus patients in there also. So there's been a bit of a shift as the production has slowed down. So these will be numbers that the children's will be watching very carefully. So that's what I had to say. I know that there was a question last time about communication with patients about what's going on. So what I said last time obviously continues. There's a lot of outreach from the surgeons to their patients. There's also been a lot of work done on the website at McGill at the MUHC to better explain what a patient can expect when they come and answers to some of their questions. So it's still in progress. We had problems with this before the pandemic, but I think that significant improvements have been brought, and I'm always happy to hear about problems so that we can problem solve a specific case. So that's what I had to say. Not sure of any questions.
Thank you very much, Dr. Sidorovich. Any questions from the members of the board? Do you have any hands raised, Tina? Not yet?
Okay, thank you.
Great.
Have a great summer. Merci.
Thank you. Chantal, bonjour.
Madame Souligny va nous présenter notre nouvelle politique de visite dans le contexte de la COVID.
Good afternoon, everyone. Our visiting policy needed changes with the pandemic, and I was invited to give you a brief update. So my name is Chantal Souligny. I'm the Director of Nursing. It's my pleasure to present these changes and acknowledge how difficult these restrictions have been for everyone since March. So hopefully in the upcoming weeks, the patient and family experience will continue to improve with these positive changes. So the objective of my presentation will be to understand the revision of our existing visiting policy for the purpose of safety of our patients and our staff during the pandemic, introduce to you key components of its implementation, present the important piece of communication plan and of these temporary changes, and to present to you our commitment to patient and family-centered care in the context of COVID-19. So why? As you all know, this is a new novel virus that is transmitted in the air, And the only way to control the spread is to maximize the distanciation between the patient, the visitor, and the healthcare workers. So just as a reminder, last March, due to the rapid transmission in the community and the concern of availability of personal protection equipment, a decision from the ministry to suspend temporarily visitors was applied. The community transmission decreased significantly recently, and the impact of missing the family contribution, we needed to find ways to reintegrate quickly essential family members and caregivers at the bedside, knowing that in this context we could ensure the safety of our patients and our staff. So how did we do this? First, we needed to find ways to relax these restrictions by allowing some flexibility so essential family members can, as they did before, contribute to the care. So we consulted our infection control specialist and our ombudsman, who received feedback and concern that they already received from patients and family. Second, we use our staff experience data, and there still exists anxiety around family having difficulties to adhere to infection control measures inside the hospital and their behavior outside the hospital like any other citizen. So we needed to keep this in mind in our capacity to ensure safety for everyone. So in certain areas, we enhanced the screening like you see in oncology, and we introduced prevention and control of infection agent like at the Pavillon Camille Lefebvre long-term care areas in Lachine. Also, we benchmarked with other organizations in Quebec and Canada. While we are respecting existing restriction, the new policy respects the guiding principle of our existing visiting policy, which made a lot of importance to the role of the family. So this means that, just to remind you about the role of essential family members, these are people that help. They are being involved in the care decision of the patient. They help with the patient's emotional support, and they help the coordination of care with the healthcare team. You also have family caregivers who provided nursing care at home or at the bedside, like at the Pavillon Camille Lefebvre, for example. So we propose with our new Family Presence policy some flexibility in this regard while maintaining a high level of prevention and control of infection measures. Here are some key messages. It is important to remember that non-essential visits remain suspended, but right now it's the exception of essential family members and caregiver. There are exceptional circumstances where these measures are applied differently. So obviously there's different circumstances in pediatrics, and now, a sibling can come and visit. In obstetric, where a partner can accompany their partner during an outpatient visit. In the inpatient and outpatient area, so any vulnerable patients where they have essential family members will now be able to come and stay at the bedside. Palliative and end-of-life care. The restrictions in terms of the number of visitors were high. Now we allow more visitors to be at the bedside during those difficult times. And again, the whole notion of allowing essential family members and caregivers. So it's mostly in the number of visitors, the duration of the visit, and planning the visit, and to make sure that we use proper personal protection equipment. The essential family present is determined as well by the clinical team and the patient. So of course, there's no risk. It does not exist, but there's way to mitigate them. And we thought that the best way is to educate, support, and coach our families. So you need to expect changes in the policy and ongoing reevaluation with the epidemiologic context and also transmission context within the hospital or within a specific unit. These all the time will take place in phases. Just to give you an idea of how a visit is planned, so visitors are always screened for symptoms upon the entry at the hospital. We ask them to sanitize their hand and is given a mask if they don't have one. Then the visitor go to the exception table, as we call it, to speak with a healthcare professional. This person at the exception table calls the unit of the patient, of the visitor wishes to see, to get the green light from the unit. If the visitor is there for a one-time visit, then the visitor is invited to go to the Family Presence Support Center and talk to a healthcare professional where he will receive verbal teaching. He will ask to sign a consent form and then is allowed to proceed to the unit. But if the visitor is an essential caregiver where he will come on repeat visit, the visitor will go to the Family Presence Support Center to watch more in depth an infection control video, will be asked to sign a consent form, and then will be given a green bracelet. So for the subsequent visit, the essential caregiver will show their green bracelet, always sign the visitor present log to declare that they have no symptom and no contact with any COVID positive person, and then they will be able to proceed, and it's a faster process this way. Just to give you a picture, so you see here at the front of the hospital where the screening take place, and then we created on the right, this picture is the Family Presence Support Center, where the visitor can meet the healthcare professional to have their teaching and go through the more detailed questions and be given his bracelet. So, of course, how do we keep up and make sure that everyone is aware of our modified visiting policy and the essential family presence policy? So we've created posters that are on all nursing units. And also we have updated and make sure that all the information is available on our webpage. So you can click on the visitor family top menu area, or there's the special icon for the COVID where you see patient and family for the COVID. You click on that and it will give you details instruction per circumstances in pediatric, obstetric, if you are an outpatient, etc. And then you can have the instructions there on how to proceed. We have also in the main message, the telephone main message of the hospital. Now, if you call the hospital, it will explain that visitors are now welcome under certain conditions, and to visit our website for more information, and to always call the unit before visiting for more information. But of course, as we said, visits are still restricted for non-essential, but there are ways and there are alternatives that are offered to our patient. So we have a facilitated virtual visit. We provide tablets to help a patient connect with friends, family members, important members for them through FaceTime and Skype, for example. And all this information is as well on the website. And we also facilitate assistance for special telephone call. So we are following our patient experience data to monitor the impact of these visitation restrictions. So our quality department provided this data, and we look at it on a regular basis. And so far, about 85% of our hospitalized patients managed to keep in touch with friends and family as much as they wanted. But of course, we can always improve, and questions are asked to our patients and families as to what could we improve in order to facilitate and decrease the burden of limiting visits. So they say that we could provide a better public internet connection. Sometimes it makes the virtual visit connection a bit difficult. Allowing one visit per week at least instead of the one-time visit for the non-essential family members. And they would like the clinical team, for when visits are not possible, to call the family to provide news more often. So these are very important feedback, and we are taking it into consideration to improve continuously. So I'd like you to thank you for listening, and I hope this presentation provided key information on our family presence policy during COVID, its rationale, the importance to educate essential family members to apply the infection control measure when visiting, and especially where to find the information on planning a visit or using an alternative mode to visit. Thank you very much. Is there any questions?
Questions? We'll see if there's some questions. There might well be. Tina, do you have any hands raised? No?
Well, I'm glad.
That's how clear it was then, Chantal.
Very happy
Excellent.
about that. It's not
Merci
an easy
infiniment.
subject. Thank you very much.
Très important comme discussion. Good. OK. On approche maintenant pour une deuxième fois. Cette fois-ci, on va le couvrir. Equity, diversity, and inclusion. I think in your books you have a draft resolution, which should be 4.5.2. But maybe just to back up, and I think it'll be put on the screen in a moment, but to back up, Dr. Feller a couple of weeks ago indicated, and I applaud him for so doing, that we could not ignore everything that was happening in the United States, and we could not think that Canada was infinitely better in some of the social issues that are being faced. And I think that while we're not aware of huge problems in our own environment, we should be vigilant, and we should be even more vigilant now. And to take this opportunity and the momentum of what is happening in a positive way to act. And so last week we had an informal meeting of a number of members of the board to have a discussion on what we might actually think about doing. And this is a very broad subject and includes many different sectors of the society in very different ways. It includes our patients, and it includes our all those that work here, volunteer or regular workers. So I think that Dr. Feller and I join him in his thought that we are very anxious to have an environment that is welcoming to all from all perspectives. And we thought that the best way to do that might be to create a group of people who are very thoughtful in this area. And I'm delighted to announce that Sita Ramdas and Anita Brown-Johnson from our board have agreed to co-lead a committee that we would propose to the board that we would create today with the support of the coordinating support of Judith Harrell, and that we deal with this as best we can, and it's about not so much about making press releases, it's important to express views there, but I think it's about doing something tangible. And I think, Dr. Feller, I don't know whether you wanted to add something at this point, but that was how this came about.
Maybe a few words. You'll remember that in the fall we had started listing the elements that we would like to consider in our forthcoming strategic planning exercise, and one of these items was EDI, equity, diversity, and inclusion. And then COVID came, and then this strategic planning exercise was put aside for the moment, as I was saying earlier today. And then the events that happened in the United States over the last few months really shocked everyone. I mean, we saw again the newsreels of what had happened, the tragic deaths of at least 3 persons because of their color, the color of their skin. And then the Black Lives Matters movement really took a lot of importance in the U.S. and also in other countries. In Montreal, there were demonstrations, and also in Europe, all over the world. And about a couple of weeks after that, I came out with, after one of the webinars again, we came out with a strong affirmation of the importance of the subject and what we wanted to do about it. Even though we don't think we're worst of class on these matters, there's always room for improvement. Of course, we had discussions with some members of the boards, with the chairman, and also with members of top management. And we decided we would have to move forward with a systematic approach to this question. We're not the first ones who are coming forward with such a program or such an exercise, a very important exercise. McGill has done it. The governments are moving forward as well. We just learned last week that Dr. Lionel Carman and Madame Giraud, who are both ministers, were named by Premier Legault to head a committee at the level of l'Assemblée nationale et du gouvernement. So we had a discussion with some board members, and we think it's time that we come forward with a systematic approach to all aspects of equity, diversity, inclusion, and all types of discrimination, be them linked to race, language, religion, beliefs, sexual identity, sexual preferences, and some others as well. So, and we'd like to go further than words, deeds, words, yes, but deeds as well. What can we do better at the MUHC in the organization? Even though many steps have already been taken, and we will have time to review these steps, things that have been done by the users committee and some committees working on EDI aspects at the MUHC. I've already introduced the topic with our union representatives during one of our weekly conferences that I'm having with them during COVID. At first it was daily, but now it's about once a week. And they obviously they want to participate, they want to be heard and tell us stories of their union members during the work will be that this committee will be doing. C'est à peu près ça, Monsieur le Président, which I wanted to add.
Thank you. I'm delighted 100% of the board was here for our in-camera, and 100% less one is here for this meeting. The one that was not able to join us for the second portion is Suzanne Fortier from McGill. She had a conflict, but she did write me on this issue saying that McGill has got a strategic plan for EDI, and that she would be welcome to us to engage with her on that. And I think that's a very great offer, and I think that they are sort of the first university out of the box to do that, which is encouraging. This is a nascent committee because it doesn't exist yet. It'll exist if everybody approves its existence today. But we did have one meeting on it. We have a draft resolution which is partially on the board because it's long and it takes 3 slides to talk about it. But I just want to ask the board whether they've got their own copies in the materials, just to make sure that they actually were able to find it. I'm seeing a head nod there. That's great. Okay. the framing of this, I think, is worth some explanation so far, and then comments by others on the board would be welcome. And maybe I could ask Sita and/or Anita to perhaps describe how this resolution got pulled together and any thoughts that they have on it. Does one of you dare take the lead? I can't see Sita, but I suspect that she's there.
Can you hear me?
There she is. Okay, great. Did you want to jump in maybe and just speak your thoughts on the creation of this committee, Sita?
Well, Anita was going to address it for both of us. I think she's just having a little lag in connecting, so I'm just going to give her a minute.
Could you be closer to the microphone? We can't hear you that well.
Yeah, Anita was trying to connect. She was going to speak for both of us, so I'm just waiting to see if her connection actually clicks in before I jump the gun.
Okay, I think your connection's not that great. We didn't, in the room here, we didn't really make out what you said. Maybe I can ask Anita to jump in.
Okay. Oh my goodness. Am I being heard now?
Yes, Anita.
Clearly? Yes?
Yes.
Yes.
Okay, great. Sorry about that. I've been struggling with some technical issues. I'm actually having an echo right now, so it's a little difficult, but I'll do my best. First, let me just say what an honor and pleasure it is. Excuse me, I'm going to try to disconnect here. The echo is impossible.
If you have two...
Okay, are you still able to hear me?
Yes.
Okay. So yes, it's an honor and a pleasure to work together with Sita and the board and all the other members that will subsequently be invited to work with us on this initiative. As our board chair and our CEO, Dr. Feller, has just described, we know that there are serious challenges, and despite progress and societal reform, racism still lingers with negative health impacts, including, among many others, diabetes, mental health disorders, HIV, AIDS, heart disease, stroke, sickle cell, hypertension, etc. Hence the urgency when we think of chronic diseases and complexity of care. We don't necessarily think of certain health inequities and social determinants of health, which is being shown in the literature more and more to have a significant impact on health outcomes, sometimes even more so than the actual quality of medical care. So again, the urgency, I think, as a healthcare institution, it's very heartening to see our board taking this situation seriously and wanting to be a leader in addressing, these types of disparities across all marginalized populations, including but not limited to the categories already outlined by Dr. Feller. In this regard, what we're proposing to do is to have a steering committee that would work in consultation with other work groups, ensuring that every stakeholder has an opportunity to voice their concerns and to contribute to solutions. we really want this to be solution focused. We want to begin by identifying what is the status of affairs within the MUHC and how can we better link with our community partners to address this very broad issue. And partners would include McGill, but also other community stakeholders. We are hoping to invite any number of groups, including the indigenous population, including individuals with disability, including clearly the Black population, which was kind of at the impetus of the recent social activism, if you will, as well as LGBTQ populations and other marginalized or underrepresented groups. We hope to include, we will be inspired and guided as well by some of the activity at McGill, where I am also, happy to be involved. And I would certainly hope that our board will have, we will have 100% endorsement of the board in terms of the work going forward, which will be significant. Our goal is to have a preliminary report available by the end of the fall, which we would first share with the board and secondarily with the community, the MUHC community. Sita, would you like to jump in here in case there's anything I've overlooked?
No, I think that you pretty much covered it. Can I be heard well? Am I coming in clearly, everyone? Okay.
Yes, I'm
so
hearing.
I think that Anita covered it very well. I just wanted to add that within the MUHC, for about 30 years, there's been a wonderful initiative that has been at the children's with the Social Cultural Education Services Department. It's made a lot of headway in the EDI area for those last 3 decades. It's our golden nugget within the MUHC, and we will be using that department and the strides in this area as a guide for the work that we're doing. We understand that it is about action. At our own users committee, we have taken similar types of action, and we will be engaging, as Anita said, with the MUHC.
Sita, I think we're being defeated by technology here. I think I'm seeing some faces on the screen that are indicating that they're not hearing it any better than we are here. I apologize.
Oh boy.
I apologize
That's
for that.
Okay.
Okay.
Can you hear me at all?
That's actually better. If maybe when you're closer, it's better.
Yeah, I know. I just must have this gigantic head on everybody's screen. But I was saying that I'm also involved with Dr. Carman at the provincial level on the group Action contre le racisme. So I'm also strategically placed there. And, with Anita's work with McGill, my own work with the McGill State community, and having some representation.
I think we're going to have.
Level.
I apologize, Sita, but it's just not coming through enough so that we can understand what you're saying. I know you're saying something important, but I just don't know what it is. Judith?
No worries. It's unusual.
Are you going to speak to a microphone, Judith, just to jump in? Judith is going to paraphrase what she thinks you're saying.
So I think what Sita was trying to convey is that she will be working with Dr. Carman on a ministerial initiative, and Anita will also be working with the university, and that those 2 elements will come to help support and inform the other parts of their work.
Excellent. That's good news. Thank you. And we'll open it up for questions now, and I think Sarah has a question. Sarah, what's your question?
It's not a question, Peter, so much as a comment. Having participated in a couple of these kind of things over the last number of years, both in a university and in a corporate environment, I think a really important part of the exercise is the listening. And in the mandate, I don't see anything about listening, right? So there's a mandate about identifying metrics and initiation and so on. But I think Anita referred to it, that they would engage with the communities that might be implicated and that we're really trying to help and understand. And I don't see that component of it within the mandate.
I think that's a basic comment, and I think it was, who was it? It was the chairman of the Royal Bank, the president of the Royal Bank, who said that he'd attend in an article in the Globe and Mail, who said that he'd attend in all these meetings, but he'd realized that he hadn't listened, which is quite an acknowledgement. But I think that's the point you're making. So Judith, can something like that be included? And I think you and Rita and Sita and Anita rather can do. Did you have a further comment, Sarah?
Well, I think as an extension of my comment, I think it's important that we communicate to our communities that this group will be listening to them. That means maybe having some focus groups or very deliberate listening sessions. Mm-hmm. So I think as part of the listening, there needs to be work around that and communication around that. So not quite sure how you build that in, but I would like an addition to the mandate.
Sure. I think that's consistent, I think, with the desires. So yeah, we'll try and get that included. And Dale, you have a comment?
Well, I guess it's just to build on Sarah's, and I had a bit the same question, and I did think it automatically, for this group to function, there would need to be a very extensive consultation process, as we see it, with other initiatives of this nature, so that it would be grounded in people's stories and experience as a starting point. But I think, Sarah, you and I are kind of saying the same thing. And I thought with Anita's comments that that's kind of what was planned as part of the process, was a very extensive consultation with people in general.
Thank you. Yeah, that makes sense. Sorry? Kevin, you want to jump in?
Yes. Well, I just want to say, one, I support obviously very much this whole initiative. But I also think that many of these things have been studied to death, and we really need to focus on results. And it's the enemy. Perfection is the enemy of getting things done. So that we should always keep in mind that whatever comes of this, we should be putting forward things that could be tested, things that could be road tested, fast tracked, or whatever that can help the organization move forward in a concrete, visible way to all these populations. That's my only point.
Thank you. I think you may have been inspiring both Sita and Anita, because if you notice the description that they gave themselves for their committee it's not a committee on inclusion, diversity, and equity, but it's a committee for action on inclusion, diversity, and equity. And I think their acronym is CAID. SAID. Good. Any other thoughts?
So are you able to hear me again?
Yes, we can.
Okay, great. First of all, thank you so much for those very thoughtful comments. Dr. Pritchard, you're absolutely right. I think the first word in our description of the mandate was engage with the MUHC community. And that's because that's really first and foremost in our minds. I agree the rest of the sentence probably was a bit too pointed, but we most definitely would like to see a parade of stakeholders coming through and consulting, having the opportunity to voice their experiences and comments and their views and vision for potential solutions. At the same time, Kevin, I appreciate that, yes, a lot of work has been done in other settings in the past, and we need to be informed by that and work upon it. On the other hand, there is still much to be done, and we want to be able to, we want the stakeholders' input to help us find those efficient solutions. We'd like, for example, to be able to come back to you with low-hanging fruit that we could implement very quickly, because it's so obvious based on previous literature and based on all that we have learned during the consultation process. We do not want this to be a non-ending, study, if you will, or consultation process. We would like, there to be action that really does make a difference, and in addressing the issues that are revealed, if you will. So thank you both for your comments.
Okay. If there are no further hands up, then we can look for a. Would Anita and Sita be prepared to propose and second this motion? My guess is yes. Great.
I would say yes, but with the additional specification of, just to make it clear about the active listening, which is embedded and at the heart of this.
Okay. Taken note by Judith Harrell. Okay. Tina's going to read the comments that Sita wanted to make, so we'll just wait for the vote for that.
She said sorry for the audio issues, but she was trying to say that they will engage with the MUHC community, both internal and external, through active listening to all voices in an inclusive and open manner, and shaping these actions collectively.
So we were not defeated by technology. Good.
No.
I think everyone can subscribe to that, and so we'll proceed with the vote. All in favor?
Aye.
Opposed? None? Good. Now this is we know the leaders, those members of the board who we don't want. I think the objective was not to have a committee of the whole, have 20 people on the committee, and not to exclude ourselves from those others that are outside the community of the board, let's say. So probably 8 to 10 people would make sense, but those members of the board who are very anxious to be involved with this should let me know, and I will pass that on. And in terms of their inclusion on that committee. So thank you very much, everyone. And we will now move to the public component of the meeting, and we'll begin with this is the public question period, and we will deal with the answers to the questions. This is not Johnny Carson's show, but it's the answers of last month's or last meeting's questions that Dr. Feller now has the answers to that he didn't answer.
Okay, so these are complements to some of the answers that were given already. So there was a complement to a question asked on January 27th about the access to the neuro. At that time, Madame Kathleen Savoie, I'm not sure if it's not Nicole Savoie, but I might be mistaken. Nicole Savoie, I think, is a volunteer. Yeah, Kathleen Savoie asked the question when the neuro is going to move, and there were also questions on access to the neuro. So, Monsieur Pierre-Marc Legris has written to me. Je devais me rendre au comité des usagers du 27 février pour en discuter avec eux. Cependant, le 27 février était une journée de tempête et ce comité avait été annulé. Suite avec la COVID, le comité n'a jamais été replanifié à ma connaissance. Nous traitons depuis l'année dernière plusieurs enjeux d'accès aux neuro. Plusieurs actions sont en cours avec la Ville de Montréal, mais je dois dire que les correctifs n'avancent pas très vite. So, on est à l'écoute, puis j'imagine que quand il y aura, when there will be once again a users committee of the neuro meeting, Monsieur Legris will be available to meet with the committee. Second question, we gave some elements of answer to Monsieur Alan Hogg of the RVH Patients Committee. His intervention and question was about ER overcrowding, but he did report that there was one case of one person who couldn't go home just before Christmas because the discharge required the signature of a physiotherapist and there was no coverage over the weekend shift. Alors, I got the answer from Madame Antoinette Diré, who is our Director of Multidisciplinary Services. We verified with the patient ombudsperson, and their office did not receive a formal complaint from the patient noted in this letter. The physiotherapy manager verified the weekend schedule dating back to November, and all shifts were covered 7 days a week. We've had for years 2 physiotherapists on weekends and statutory holidays at each of the sites, Glen and MGH. One of the priorities for intervention for these people are patients who are to be discharged. This is in order to decant the ER of those patients who need not to be there. As of January the 18th, 2020, we have increased physiotherapy staffing on weekends and holidays. We are in the process of recruiting, and we hope by April to have a total of 5 physiotherapists working weekends at each of the sites, Glen and MGH. As well, OTs, occupational therapists, ergotherapeutes, have been introduced to weekend shift. Just a sec. We will have 3 occupational therapists on weekends and statutory holidays at the Glen and 2 at the MGH. This has been made possible through specific funding received from the MSSS to decrease length of stay given the high demand for acute care beds. Criteria have been established as to which patients these clinicians will be intervening with, and again, patients awaiting discharge will be a priority. Please note that social workers and clinical nutritionists are on call weekends and statutory holidays. This has been the case for years. As you may be aware, the allied health professionals work only on the day shift, weekdays and weekends. There is no service at night, on evenings and at night. So that was the answer to Monsieur Hogg. Then there was a question from Mrs. Kelly, Maureen Kelly, RVH Patients Committee, member of the Functional Accommodation Subcommittee. The question, Mrs. Keeley's question was about a public pharmacy. So, of course, Monsieur Legay answered that the pharmacy should be open in July of 2020. Of course, we've been using these surfaces, these spaces for our screening process of COVID. So, of course, there has been delays. I don't have the details of what's expected because we just came out of the COVID period, the first wave. But I guess, and Monsieur Legris is not here today, the plan is always to have a pharmacy in these spaces, unless someone knows something else. Est-ce qu'il y a des changements? OK. Est-ce qu'on a des changements là-dessus? Yeah.
Oui, il y a la clinique de dépistage. Là, on est en train de faire un plan à long terme et c'est dans ces
espaces-là.
Oui.
OK, il faudra qu'on ait un peu plus de... On va répondre de façon plus précise. Là.
Peut-être, Dr. Fallard?
Oui.
Donc, l'espace de la pharmacie demeure. Donc, on va prendre seulement 1000 pieds carrés pour les espaces de dépistage. Le reste de la pharmacie va avoir lieu.
Qu'est-ce qui parle? Alain. Ah, OK, parfait. Je ne savais pas qui parlait. Donc, Alain, qu'est-ce qu'il a dit? Je m'excuse, j'ai mal compris.
Donc, la pharmacie va avoir lieu, mais on va prendre seulement 1000 pieds carrés d'espace.
OK. Donc, les plans sont modifiés, mais on aura une pharmacie éventuellement.
Exact.
Merci beaucoup. Come get your phone done. I'm not wearing my mask. OK. Et puis, la dernière question, Dr. Kevin Schwartzman. The question was, how is the MUHC planning in concrete terms to shift human and material resources so that it can once again focus on providing tertiary and quaternary level care to patients who have been kept waiting? Well, that was part of the presentation by Dr. Siderovitz on the ramp up. Voilà, ça c'était fait. And I have one question from this morning. The question is from Madame Lorna O'Coppin. Madame Coppin, she's a neighbor of ours. Her office is right next to mine. She works for ambulatory surgical services. So Madame Coppin is writing, thank you, Dr. Feller, for your acknowledgement. Kudos to the MUHC for taking this step in regards to Black Lives Matter. Making a policy and implementing changes is a big first step. This change is needed and necessary. Accepting and following up on these changes are vital. In moving forward within the MUHC family with all our community and cultural differences, equity, diversity, respect, communications, acceptance, and inclusion for an individual or a group. Follow some questions. 1, how will the changes from top-level management to bottom-level employee be incorporated, inclusive and representative system for all? How will the board of directors within the MUHC family be transparent? How will feedback be given? How will the employee be given an opportunity to voice their concerns? What type of evaluation process will be used? With what timeline? When will feedback be given? So I went to see Madame Coppin this morning before our board meeting, and I thanked her very much for her questions. I told her I didn't have the answers because we are just creating the committee this morning, but the answers will be forthcoming. Madame Coppin understood the situation and thanks us very much in advance. Voilà.
There's one more question?
If we have time.
Okay. Yeah.
Okay.
The question we received was Marie-Jo Pierre asked, when using an iPad provided by the hospital, which internet connection is being used by the patient? I think we'll...
I don't know which internet connection I'm using, so...
Maybe we can get back to her with the technical answer to that. Right. Thank you. Okay.
Mais il y en a deux. Il y en a un, c'est probablement public qu'ils doivent prendre, mais probablement qu'ils doivent programmer spécialement pour les usagers, pour pas qu'il y ait de bris de communication. Donc, je pense qu'il faut parler avec M. Bodo et son équipe.
Puis, il y a peut-être un lien aussi avec le système de télévision qu'on a fourni gratuitement à tout le monde. Il y a l'Internet là-dessus. Fait qu'il est possible que la tablette soit adaptable là-dessus, là, mais je ne le sais vraiment pas. Là.
D'accord. Merci pour la question. Are there any comments or questions from the board on anything? No hands up?
From the public, there's one hand up from Michael Bird.
We have hands up in the public. Well, our questions are supposed to be submitted 1 day in advance so that it gives us an opportunity.
Either we take the question from Mr. Burry or we take it after the meeting and we answer Dr. Burry and I give a feedback at the next meeting on the question.
I think that's the best way to do it.
Okay,
yeah.
perfect.
Thank you. Sita? Oh, gosh. Okay, let's try again, Sita.
Can you hear me now?
Better.
A little better?
Yes.
I just wanted to say that I know Lorna, and I'm very proud that Lorna submitted those questions. I think that they echo a lot of what is part of the task that we have to do, and they will guide us in accomplishing those tasks. So I'm grateful that she submitted those questions.
Started out so great. We had the beginning of that, but we missed. It seems to disappear as though the battery dies or something. We'll have to find another way to communicate with you, Sita. That's going to be more resilient. But I do want to thank you and Anita for volunteering to chair this committee, and we wish you good luck in accommodating all the variety that you will live with, and we will help to the extent that we can in helping you get that kind of work done, which is very important. Oh, now we have it. Tina will read Sita's comment.
Sita says, I know Lorna. Glad she submitted those questions. They will guide us.
They will
Excellent.
guard us?
Guide
us.
Yeah. Is there anything else that should be brought before the board this morning? If not, I thank everyone for their attendance and comments, and I look forward to seeing you on the screen or if it's possible in person at our next meeting. Thank you so much.